Hello dear friends and colleagues. Welcome back to my channel. My name is Panagiotis Georgiou and I'm an ENT consultant trained in Germany based in Cyprus. This channel is all about delivering distilled information about ENT topics to facilitate you in your revision process, either if you're an ENT consultant, ENT specializing doctor, or a student that wants to learn more about an ENT topic. Now let's jump right into our today's topic, and this will be congenital neck malformations. The most common congenital neck malformation and what we're about to talk today is the thyroglossal duct cyst. Now, as you can see here, by definition, it's an incomplete obliteration or incomplete degeneration of the thyroglossal duct. If you're just now learning the topic, you will need to know that during the embryonic development, usually at the 6th week, we have a migration of the thyroid gland tissue from the base of the tongue, from the foramen caecum, towards the end position of the thyroid gland in the midline of the neck on the level 6 by Robinson's classification. Now, if you can see here in the picture, the thyroid gland starts, as we said, in the foramen caecum, and then migrates downwards, passing posteriorly from the hyoid bone and finds its end place at the location of the thyroid gland. Now, there is an inhibition malformation. That means this cyst that is formed, this thyroglossal duct that's formed, needs to degenerate. If it doesn't, then the remaining tissue will form a cyst in the area. Where do we find thyroglossal duct cysts? It will be either at the base of the tongue, above or below the hyoid bone, or where the end position of the thyroid gland is. Now, there are some caveats to this. For example, if the degeneration of the thyroglossal duct stops above the hyoid bone, as seen here in the picture, we have an ectopic thyroid gland that lies above the hyoid bone. And if the thyroglossal duct moves below the hyoid bone and finds its end place where the thyroid gland lies, then if we don't have a degeneration of the thyroglossal duct, we will see this thyroglossal duct cyst formation. Another thing to talk about here will be that this cyst can be seen in any age. Usually, if the patient is less than 20, like 50% of the cases present themselves when the patient is 20 years old or younger, or if you would like to see it in another way, 70% of the patients present to us by the age of 30 years old. Now, if this small cyst penetrates the skin, it will create a fistula, and this fistula can occur, but is a rare occasion. Now, for the symptoms. Usually, the patient will have a submental swelling that is elastic in touch. We will need to talk with the patient and ask in the history, in the medical history, if they underwent an upper respiratory tract infection or if the swelling occurs just after eating. And then a really good examination remark here is when the patient swallows, because the cyst is connected to the hyoid bone and the hyoid bone moves by the act of swallowing. We can see the up and down movement of this thyroglossal duct cyst. It changes in size during lifespan, especially after upper respiratory tract infections, as we said before, or after eating. And then on our examination, we'll need to perform a good anamnesis, a good ENT status, palpation, inspection of the mass. We will need to ask the patients to swallow and observe the cyst. We will need to do an endoscopy in order to recognize any swelling at the base of the tongue. And then, of course, there is the imaging techniques like an ultrasound or an MRI. In the ultrasound, as I write here for you, you will see a cyst formation with good borders that is anechoic. Now, there are always three things to remember and not forget when you are examining a patient with the differential diagnosis of a thyroglossal duct cyst. And that's the three things not to forget. Always do an ultrasound to see if the thyroid gland is there. Usually patients with thyroid duct cysts have ectopic thyroid glands, and you can find them during this road from the base of the tongue towards the ending place of the thyroid, of the ending rest place of the thyroid gland, in the neck, usually in the level 6 or just above the hyoid bone. Then always do an endoscopy in order to check at the base of the tongue, especially if the patients are hypothyroidism. The tissue at the base of the tongue tends to swell a lot, and the patient then has a foreign body sensation in the neck. They are not able to swallow so good. They have dysphagia. Then we'll need to check if there are any ectopic thyroid gland rests along the path of the migration of the tissue. Now, if you have done an ultrasound, if you have done an MRI, the patient will always ask you, "Doctor, is it important to remove it?" And you will need to say every time yes, and then answer why. Because less than 1% of this patient with a thyroglossal duct cyst can have a papillary thyroid carcinoma. Now, what are our red flags in order to act quickly? It will be when we see a solid mass formation, if the patient is more than 40 years old, if the mass on the neck is growing in size, and of course if we have lymph node swelling, or if the mass is painless. Here you can also check for Delphian lymph nodes. Those lymph nodes are found behind the thyroid gland, and you can easily see them with an ultrasound or an MRI. Always ask for an MRI before the operation. Many doctors do the operation with only using an ultrasound. That's also acceptable. But the thing not to forget is to tell the patient before the operation, while signing the consent form, that we will need to remove part of the hyoid bone, and specifically the body of the hyoid bone. The body of the hyoid bone does not play a big role in swallowing, so the patient shouldn't expect any major swallowing issues after the operation. Care needs to be taken in the postoperative period to do an endoscopy of the patient and observe the vallecula, the place where the base of the tongue meets the epiglottis, for any hemorrhage and swallow. Now, for the operation, you will need to make a midline incision on the level 6 of the neck. Usually we do the incision just above the thyroid gland cyst, and then we prepare the cyst on both sides. We follow the cyst and we follow the fistula of the cyst until the hyoid bone. Then in this case you will need to stay in the midline, and then you will need to orient yourself by always palpating the hyoid bone and working your way towards the hyoid bone. There are no major structures to damage in this area. Sometimes the anterior jugular vein gets in the way, but it's an easy ligation. And you will need, when you reach the body of the hyoid bone, there are some scissors, bone scissors, that we can see here, that you can cut the bone and you mobilize the body of the hyoid bone. Then you will need to clamp just behind the hyoid bone in order to avoid any recurrency of the fistula. And in very, very rare cases, you will be able to put a probe in the fistula and follow it up to the base of the tongue and see it coming out through the mouth, through the foramen caecum. In this case, you will need to do a neoepithelialization of the tissue in this area and suture it with a Vicryl 3.0, just as we see here. So structures that are in the way, the aponeurosis of the platysma, then you will need to move the strap muscles at the side and expose the thyroglossal duct cyst. Stay always in the midline, always follow the hyoid bone. A very important step is to remove the hyoid bone, the body of the hyoid bone, and clamp your artery just behind it in order to take as much of the fistula out as you can, using the bone scissors every time. Thank you for your time. See you in the next video. If you got any useful information from this video, like and subscribe, and I will see you next time.